21. For our COVID update. Case numbers and case rates continue to decline across the U.S. As we talked last week, it kind of was marching up the Appalachian Mountains, Tennessee, West Virginia, into southern Ohio. And that continues. Tennessee's actually, their case rates are coming down. The South is still coming down. Here in North Carolina, we're slowly declining. We weren't up nearly as high as all the states around us. They have further to fall, I guess is the way to say it, so they come down a little faster. But we are declining. Here in the Triad, we're hanging in there about mid-50s per 100,000 per day, and that's about where it's been actually for the past three weeks or so. I think if you looked at the trajectories of these curves, it is declining. Our percent positivity in our area is going down. We're knocking on 10% now here in Forsyth County. Had been up as high as about 14%. So it's not coming down quite as quickly as I thought it would, and the reason for that is roughly still about a third, sometimes a little bit more, of the cases we're seeing are in our under 18 population. And that was largely a naive population because they weren't getting COVID last spring and winter when it was surging through us older people. And so there's more susceptible people. And they're socially out there getting together, and they're giving each other COVID. The pediatric hospitalizations in our area have really not been going up over the last 3 or 4 weeks. It's a little bit higher than it was last spring. A handful of people in Brenner's Children's Hospital at any one time. Usually people from socially economically disadvantaged populations and people with childhood obesity. And we talked about that last week. Pfizer published their information, some of it, not all of it, on the 12 to 17-year-old, on the 5 through 11 or 5 to 12-year-old kids trial. That'll be going to the FDA probably this week. They'll start to mull it over. And then it looks like by the end of October, as we've been predicting all along, we'll have an emergency use authorization for Pfizer's vaccine in kids from 5 to 12. I've seen some of the data. Most of the data they're relying on is surrogate data based on levels of neutralizing antibodies, which is a specific type of antibody test. And it is at least as good, if not better, than what we get in adults, and they do it with 1/3 of the dose that we use for adults. And that's, I think, important, that we can use a lower dose for the 5 to 12-year-old group. It should limit the side effects of pain at the injection site and fever because that antigen dose is a little lower. That just shows kids mount a really good immune response when challenged. We've known that since the first vaccines were ever given. Kids always do better and respond better than adults do. And so that's something to look forward to. It's going to be helpful not only for the kids themselves and their parents, so that they can be more comfortable doing things that we would like to do, including going out more, maybe going to a restaurant, going to a kids' concert or a play, things like that. If you're vaccinated, you can do it with a lot more peace of mind. But it'll also help us slow COVID down in our communities, because, as I mentioned earlier, that's the group right now that it's really going through. And if we could slow it down in that group, COVID's going to go away a lot faster. right now, the 12 to 17-year-olds can get immunized. And I still encourage parents to talk to their kids and get them immunized. The concerns about immunizing kids from parents and focus groups kind of focus on some psychology a little bit, that the potential adverse effects of the vaccine, although extremely rare, for instance, myocarditis in adolescent boys, is about 50 per 1 million, which is minuscule. Your odds of getting myocarditis from COVID are much higher, maybe as high as 20%. The myocarditis that comes from the vaccine in kids, the 50 per 1 million, now it doesn't even get hospitalized. It's treated with ibuprofen, which is Motrin, and it goes away without sequelae, and there's been no deaths from it. So it's pretty low risk, very low risk. But I think the psychology is for a parent that they can't fathom any kind of problem that their child might get from something they did. And so that the parent makes the decision for you to go get a vaccine. You have a 50 per 1 million chance of getting myocarditis. If you're one of those 50 per million, then you are going to have to live with that. And that's the psychology. The thing that is not completed, though, in that thought process from the parent is that your child actually has a much higher risk of getting myocarditis from exposure to COVID and the natural infection. And not only that, but they have also a risk of multi-system inflammatory syndrome. They have a small but real risk of getting long COVID. And so the risk of getting COVID is so much higher than getting a vaccine. But that psychology just doesn't seem to sit sometimes for people because, oh, then that's COVID's fault, it's not my fault. Obviously, the best way to think about it is from a science perspective and from an absolute risk analysis perspective. So I encourage parents to talk to their pediatricians. I encourage pediatricians to get the real data on this and give good information. And that'll help us as a community, and it'll also help our kids. So a little bit about pediatric vaccination. So our schools are hanging in there. There are a small number of cases in our school system. I still don't know of any that are actually transmitted within the classroom or the school building itself. It's usually with after-school activities, social activities, particularly with the high school kids who are more of a social and independent group. The number of people in quarantine is roughly in the, 40 to 60 per week. I haven't seen this week's data yet. And most of that's from exposures outside of the school. The Wake Forest University is doing very well. Less than a handful of cases per day. And in fact, some days 0 cases. And if you compare it to how universities were doing this time last year, it's phenomenally good. Particularly when you consider that COVID transmission in the communities, there right now, and the university is pretty much doing everything like a normal university would on a normal day, having football games, club meetings, social events, music, friends getting together, so on and so forth. So that's really great, and it shows you if you can highly vaccinate a population of people, such as has been done down at Wake Forest, that life is a lot easier. A lot of news this week on boosters, a lot of confusion on boosters. I think the media's missed the mark on boosters a little bit. I've been saying all along, and continue to say this week, that that the people who are going to get the most benefit from boosters are going to be elderly and infirm people. How much benefit will a population with increased exposure get from a booster? It's a little bit hard to know. So if you, for instance, work at a poultry plant, would a booster help you? Potentially, because these are areas where workplace exposures and transmission are really well documented. In hospitals and places like this, we really don't have much transmission in the hospital. If a booster would happen to make it less likely for you to get a breakthrough, then we can have more people come to work, and that would potentially be good for the hospital. But we'll have to see how it shakes out. Today, the ACIP is meeting. That's the CDC committee that decides really who would benefit the most and how should it be done. I wanted to relay some, I was privy to hearing some of the discussion and concerns from the FDA advisory committee meeting last week on boosters. And here's what I think is clear from the data, and then I'll tell you what's not clear. What is clear is that we still have high efficacy from the 3 vaccines that we have approved in the U.S. for symptomatic disease, hospitalization, and death. And in fact, our data now, as of September 8 in the U.S., shows that if you've been vaccinated, your risk of being hospitalized is 0.005%, and your risk of dying is 0.001%. In the UK, they have now shown that of all of their hospitalizations due to COVID, only 0.5% of them are in unvaccinated people, and so that's actually the number is a little different. It's 0.5% of people who've been vaccinated get hospitalized. So, and that's with the AstraZeneca vaccine there, which is maybe not as good as their messenger RNA vaccines. So, so it's pretty clear the vaccines are working, and that includes against the Delta variant. The committee thought that the data was pretty good, that, in fact, very good, that the current vaccines are protecting against severe outcomes with Delta and all of the other variants as well. Against symptomatic disease, it would seems like, so these are the people who get COVID colds. They're not quite as good against Delta as they were against Alpha, but it's a modest decrease. There were some things pointed out at the committee that were concerns about widespread giving people boosters. The first one is that robustly immunizing half of the population and not having the other half immunized doesn't really gather you any traction against the pandemic, because it's the number of people and the total pool of people that are immunized that makes the difference. Two is that there were some concerns about something called immunologic imprinting, which means that if you get a booster vaccine and you've had 3 vaccines, that any future vaccines that you might get might have reduced ability to mount a good immune response. And that's well sorted out and known in science. We don't have great data for the messenger RNA vaccines yet, if that's going to be the case. But it certainly is plausible. And there is a vaccine now that is out. At least it's been made, but not yet submitted through the regulatory process, that actually is a Delta-based vaccine that would have enhanced activity, particularly against Delta, as well as the other variants. And the thought is that sometime, probably not in the too distant future, that this vaccine would be fused with what we now call the Ancestral Vaccine, which tells you a little bit about how we think of the, as far as boosting. The Ancestral Vaccine is the vaccine everybody got last winter and spring. So if you put that together and the Delta one together, then you got an enhanced Delta vaccine. And that's maybe the one that might be a better one to get. The other consideration that was discussed at the FDA's meeting was that if you have a bunch of people rush out and get a booster all at the same time, and if there is a small but real signal for an immunologic side effect, such as myocarditis, it's going to appear like there's a bolus of that, right? Because everyone went out at one time to go get it. And that might decrease people's excitement about getting booster vaccine in the future. The third thing is that the data that supported boosters, most of it was from Israel, and the information really tells you only about reductions in symptomatic infection at a 7-day endpoint after vaccination, because it just hasn't been enough time yet. So is it going to be the same at 30 days, 60 days, 90 days for a reduction in COVID colds? We don't know. We know it at 7 days right now. And then lastly, is that there's going to be a lot of information coming out in October from 3 NIH clinical trials about what I call mix and matching vaccine. So you got Moderna initially, you get your booster of, quote, booster of Pfizer, or you have Pfizer initially, you get a booster of Moderna. If you're one of the J&J people, should you get a second J&J vaccine, which actually will work better if you did? I said all along J&J should have been 2 doses from the get-go. Or should you get a Moderna vaccine, or should you get a Pfizer vaccine? Exactly how is it going to do? So there's 9 different perturbations of these 3 vaccines. And we'll have a lot more information in October on how that goes. So if you rush out and get Pfizer's now as a booster, and then we find out in late October you should have gotten Moderna, you can't just going to go out and get another Moderna then. You just can't add vaccines like that. So it's not like buying different flavors of coffee at the supermarket. So the ACIP is meeting on a lot of this today, and so we'll see what they say. We always hear quick here at Wake Forest Baptist Health, because one of our pediatricians who's an expert in vaccines is on the ACIP, Kathy Paling. So she's got a busy day today. So more data has come out now on vaccines and pregnancy. It's really, really, really reassuring, actually. Getting vaccinated in pregnancy is safe, and it is effective. And you get the benefit from your baby will have 3 months of your antibody against COVID. So if you're pregnant, go get vaccinated. It's a great thing to protect you and your baby. So I think, as flu season comes up, is October 1, that's next week. Time to start thinking about getting a flu shot. I have a little bit that's not the right way to say it. I am predicting that we will see more flu this year particularly than we did last year, because we didn't see any. COVID basically knocked it out of the ballpark. But this year, our other respiratory viruses have seemed to make a comeback, which makes me think that flu will also. So let's get our flu vaccine. If you are somebody who wants to get the COVID booster and you're in one of the suggested groups to get it, which again we'll know later today, probably older and infirm people and people with underlying medical problems, you can get flu and COVID at the same time, one in each arm, and makes it easier and more gives you more time to do other things. Yes. So we'll talk a little bit more later about how the booster rollout will go. Here in North Carolina, I don't think we're going to have large mass vaccine clinics like we did last winter and spring. I don't think you're going to see the health department down at the Dixie Classic Fair. One good reason is because the fair will be there. Carolina Classic Fair, actually. Sorry, I got old name stuck in there. But I think that they'll be available through some primary care providers. There will be some special vaccine clinics. But I think that here in North Carolina, where we really would like a lot of these boosters to be given are in retail pharmacies. And retail pharmacies will be actually, the number of them that'll have it available will be expanded. So a little bit about that. So with that, I guess I'll ask if there's any questions. Hearing none, next week I will be at what we call ID Week, which is the largest infectious diseases professional meeting in the world. We'll be moderating some sessions there and sharing information. And then also gathering information on COVID and other infectious diseases. And we'll get a chance to chat with Tony Fauci. So I won't be here next week, but I will the week after, and I'll let you know what I learned.